Okay, this video is advice for doctors in residency. So people who finish medical school and they're going into their residency. The first year is called internship. After that, you're a resident. Some people call internship first year of residency. A lot of people do transitional internships in internal medicine and then they switch over to something else, like an internal medicine subspecialty. I did my internship in surgery and then switched over to radiology with the plan to go into interventional radiology. Okay, the first thing to know is it's hierarchical system. It's almost like the military. When you're the intern, you are the low man on the totem pole. Your job is to just get the work done, do as you are told. Nobody expects you to know much. Nobody expects you to think much. You just need to obey and get the work done. Sometimes your senior resident will be a jerk, will be an idiot. It doesn't matter. There's an old saying, you salute the rank, not the person. Salute the uniform, not the person. So what that means is your senior resident, whoever's beyond you, supervising you, they're responsible for you. So you have to do what they say. If you dramatically disagree with them, you can discuss it with them. But in the end, their name is on the chart in charge of you, so you have to do what they say. What do they want from you? The number one thing they want from you is to get the work done fast so they can go home. Everybody's always tired. Everybody's always overworked. So the main goal is to get the work done fast so they can go home. The next thing is you're expected to make them look good. Never embarrass your senior resident or your attending or they'll hate your guts. So they want you to make them look good. So your job is to try to do that. And again, the main thing they care about is get your work done fast. They'll give you a whole list of stuff to do for that. It's called SCUT work, which just means sort of SHIT work, tedious stuff that needs to be done. Okay, now what is it that they don't care about? They really don't care how smart you are. They expect the interns to be kind of clueless and not know too much. They think it's funny. But they want you to just be able to get the stuff done that needs to get done. They expect you to know that, and they'll explain it to you usually. Sometimes they don't even explain it to you. Sometimes you have to go do something and learn how to do stuff. For example, later on, when I was an intern, I didn't have to start IVs. Even though it was a surgical internship, I didn't have to start IVs. In my regular residency, I would have to start tons of IVs. And I didn't know how to start an IV industry. I was just awkward at it. So what I did was I went to the blood lab for blood draws, and I just asked them if I could volunteer to do blood draws all day long. And I did, and I got very comfortable with it. After that, in my residency program, I was great at starting IVs. I would start them in the forehead. I would start them in varicose veins in the abdomen. I would start them in the foot, anywhere. So that's how you get good at stuff, by doing a lot of cases. If you want to get a job at the program where you're training as a resident, then they need to like you. The more they like you, the more likely they are to give you a job if you want to stay in that town. They really don't care how smart you are. I was super smart. I was done with my boards, 4.5-hour test, an hour, 10 minutes with a perfect score. Okay, and I was really good at doing procedures. But I really, I didn't really care that much. I did my residency at Northwestern, and I was a little pissed off I was at Northwestern. I had a little bit of a chip on my shoulder. I sort of felt it was beneath me. I belonged at Harvard. So, and they didn't really like me that much too. I sort of felt the place was a little bit wimpy, and it just didn't really like aggressive people like me. At our program, the first day, all the senior people in the attending sat in the front row. I sat in the front row, even though I was a first-year resident. I didn't care. I'm here to learn. I was just real assertive. Like, we had a girl from my same medical school class who was second in the medical school class. To give a presentation, she would take beta blockers. She was so nervous. And she was very shy. She was very pretty. She was very likable. When we finished up, they offered her a job. They wrote me a good letter. I got a fellowship at Harvard. But they wanted her to work there. They didn't want me to work there. I was sort of a very assertive, aggressive, smart guy. They're like, why are you so aggressive? You're like a hammer. Why are you so aggressive? And I'm like, I just want to learn, okay? I knew I was going to be great at something. So I hadn't figured it all out yet when I was young, but I was way more assertive than the throttle idling level of that program. For me, giving a presentation, I'm like, this is nothing, presenting for my co-residents and the attendings of my own program. I go, I would volunteer for presentations, show off, okay? So I was very different than the average resident. She would be more like the average resident. Nervous, I need beta blockers to give a presentation. Let's see, what else? Let's see. Yeah, if they think you're smart, they'll write you a good letter, get you. It makes their program look good that you got a fellowship at a good place or a job at a good place, but they won't hire you. It doesn't matter how smart you are. If they don't like you, they won't hire you. Let's see, what else? What should you not do? You'll hear your attendings and senior residents make fun of other services. It's a very common thing that surgeons will make fun of internists or radiologists will make fun of internal medicine, but you should not do that. Because number one, you want to get along with the other services, and even though your attending or senior resident might mock the other service, if you're nasty to the other service, they might hate you for it or get you in trouble for it, and just be nice and get along with people. That's a very important skill in medicine, is just getting along with people. And I always have found it's in my best interest. Even I like talking to other services, but I'm nice to them because also they come to me for help. And they come to me for help. They show me the most interesting cases. And over the course of my whole career, I've always been very nice to the other services. And part of that's because I never really cared when I went home. You know, when I was a resident, I didn't have much of a social life. It was not really in a very good area, so there were no social events. And what I'm saying is, see, a lot of people, the reason why they're nasty and rude and they don't communicate or they ignore the other services is because they just want to go home. Anytime you do a favor for a clinical service, it usually means they're asking you to go over a case or help them with a difficult case. And what that means is you're doing extra work that you don't want to do, and you get stuck having to stay late. And it becomes a big deal when you're stuck having to stay late every single day. And so that's why a lot of people, they have this demeanor of being friendly to their own group because that's where they get a potential job or a potential recommendation letter, but being nasty to other services. I was not like that. I was always very nice to the other services because, again, I liked them. I was kind of friends with them, and I learned from interacting with them, and I felt it's important to be a good consultant, and I felt it would help me to become a better doctor, helping them out with whatever they needed and with the difficult cases. And all through my career, even now, I'm always helpful to other services because, number one, I think that's the right way for a doctor to behave, but number two, I know from experience, they bring me all the best cases. I get to see all the best cases, so I accelerate my learning. And I learn every day, and I enjoy learning something, and it makes it more fun. And over the years, I develop a high level of expertise, which I like to have. Okay, what else you need to know? Make sure you always have a senior person supervising you on procedures when you're a junior person. And that way you don't get yourself in trouble. You know, if you're doing a big complicated case and you're not ready to do it by yourself, you could get in trouble if you have a complication and you weren't supervised adequately by a senior. So always have a senior person supervising you until you are senior yourself or you've got adequate experience. And like I did, here's a typical thing I did in residency. I hated the rich hospital. At my program, we had a rich hospital and we had a poor hospital. I said, a lot of people like the rich hospital. You don't have to do much. You got good hours. I said, screw this. I hate the rich hospital. I took all of my rich hospital time. I said, I traded it away. I gave it to other people who wanted it. I said, send me to the poor place. The reason I wanted to go to the poor place was at the poor place, there was very little supervision of the residents. They let you do big aggressive procedures. The fellows don't want it. At the rich hospital, you've got a senior attending and a fellow hogging all the good cases, okay? You go to the poor hospital, they'll let a junior guy do complicated things with very little supervision. When I was a second-year resident, I was doing, catheters, cerebral arteriograms of the brain, unassisted. The attending didn't even scrub. They were just behind the view screen. So no one else was doing that. You go to the rich hospital, you'll never touch the catheter when you're a junior resident on a cerebral arteriogram. So that's how I got a lot of experience. I got a lot of experience doing advanced procedures as a junior guy because I traded all my time at the rich hospital to go to the poor hospital. At the poor hospital, everything is done by more junior people. Let's see, what else? Always finish your work before you go home. Never dump work on other people, or they will hate you for that. That's like one of the worst things you could do as a resident or as an attending physician is dump work on other people. They will hate you for it. So then the next thing is, because everybody feels that they're overworked. So if you're dumping extra work on them and they feel they're already overworked, they're going to hate you and think you're a scumbag. Okay, so you don't ever want to do that. Okay, what else? What matters for clinical practice when you're an attending? Theoretically, they'll say, you want to try to be the best doctor, know the most, help the most patients. But in reality, people don't care about that very much. The other services will like it if you do a good job. Like I always try to make my reports or anything I write in a chart eloquent. I always make sure I try to spell everything correctly, make it easy to read. I punctuate it in such a way, make paragraphs between each line, that I try to communicate very well. I like to think of myself as a great writer, and whenever I write anything, a note, an email, anything, I always make sure it's very well done, okay? And the reason I do that is if you get into sloppiness, which you'll sometimes see because it enables you to go faster, you'll start doing everything sloppy, and all of a sudden you're just doing crap work. I consider myself a great doctor, so I want everything I do to be great. All my notes are great. All my reports are great. All my communications are great. My emails are great because everything I do is great. That's me. And so if you just make it a habit, it'll slow you down the first couple times to write your note well, to make your report well, to make your email well, whatever. But if you do it all the time, it's just natural to do everything great. So everything I do is great because I make it that way, all right? When I do a procedure, I try to do everything great. When I communicate with a patient or with a staff member, whatever staff person is, another doctor, a technologist, a nurse, I try to do everything top-notch because I say I'm a top-notch guy. And that slowed me down initially, but it's so natural for me to do everything top-notch that I just expect to do everything top-notch. And it just doesn't slow me down because I'm used to doing it that way. Okay, but now what am I getting at? In reality, what it's really about for an attending physician is speed. And so what I'm trying to say is, imagine you run a hospital. You're the owner of a hospital. What do you want? You want your doctors going as fast as possible because the faster they go, the more billing codes they generate per hour and the more money you make off them. In addition, depending on the field, in general, most doctors have a fixed amount of work for the day. Let's say they have to see 15 to 30 patients. Well, if they're seeing 30 patients a day, the hospital, the clinic, it's making more money off them. So it likes that. So there's always pressure on doctors. Go faster, go faster, go faster. Generate more billing codes, generate more billing codes, generate more billing codes. But it's also a bit of a dangerous game to play. It's like Charlie Chaplin in the assembly line in modern times, okay? You go too fast, you're going to be at risk to make more mistakes. So you have to keep on making yourself go faster and faster until you're pretty good at it so you don't make mistakes. Because, for the patient's sake, you don't want to make a mistake. And for not getting sued, you don't want to make a mistake. But that's one of the things I don't like about medicine. There's this tremendous pressure. Go faster, go faster, go faster. And you don't get paid for helping the patient. You get paid to follow the standard protocol and generate the billing code. Whether or not the patient does well or not, that's not something that gets reimbursed. If you cure the patient, you get paid the same amount as if the patient has a terrible outcome. So out of the goodness of your heart, you want the best for the patient. You want to try to get a good outcome, but you're only obligated to provide standard of care. And the standard of care is based on a patient being, demented, confused, intoxicated, whatever, unable to cooperate, unable to help themselves. So you have to really, in your mind's eye, try to say, I'll do the best I can for the patient, but I want to make sure I fulfill the requirements of the billing code so I get paid, so I can't be sued, so I please my senior resident and my attending. What you're going to be good at is whatever you do a lot of. So if you do a lot of procedures, you'll be good at putting the procedures. Like I did thousands and thousands of dialysis catheters. I could tunnel a dialysis catheter in my sleep because I had to place so many of them. Venous access was a big part of imaging-guided surgery when I started out. So if you do a lot of those in residency and fellowship, you'll be very good at them and you'll be able to do them really fast when you are an attending. If you don't do so much of something, try to get the experience any way you can, and then you'll get faster and better at it. And the faster you are doing everything, the faster it is, the earlier you'll go home. And it's nice to go home and have some time to go home. Anyways, but that's what it kind of comes down to. So what I was sort of getting at is residents are trained to emphasize doing the correct thing, knowing the right thing, knowing what to do. But then they get into practice, and what their clinical job is usually going to emphasize is go faster, go faster, go faster, go faster. So you want to both be able to do a good job and go fast, because there's a lot of pressure on you to go fast. And that, I think, let me see if I got anything else. I got one little bit more. I'm going to briefly mention this lady, Stari Stanchik. She's a lady who wrote a pretty good book about what's missing in medicine, and she herself got multiple sclerosis, but she cured herself by becoming a low-fat vegan. And she talked about that residency trains people to be unhealthy. They feed them junk food from the cafeteria or from drug reps who sponsor lunches. They're stressed out, they're sleep deprived, taking a lot of call. They end up drinking a lot of coffee, eating a lot of processed food. And she says they consider it normal to be sick. You expect the patients to all have diabetes and hypertension and coronary artery disease, and then everything related to that, which is all the chronic Western diseases, abdominal pressure syndrome, leaky gut, all that stuff, gastroesophageal reflux disease, common things like AFib, congestive heart failure. So she says you expect the patients to never get better because you just treat them with drugs for dietary diseases. They never cure the dietary disease. So everyone's used to everybody being sick and everybody taking drugs, and it creates this whole mentality that that's what health and life is all about. A medical license is primarily a license to sell prescription drugs. So anyway, she said once she became a low-fat vegan and improved her sleep, she got cured of multiple sclerosis, and that really helped her. So what I'm trying to say is try to maintain your health, try to maintain your sanity, and you're going to need to sleep, and you're going to need to eat healthy food if you want to stay healthy up into your 50s and 60s. You know, when you're 25, you can get away with, abusing yourself, being on call every other night, eating junk food, but you can't get away with that when you're after 40 and after 50. Forget about it. Okay, I'm in my 60s, okay, and I'm just, trying to stay healthy by having good habits. So, anyways, that was the key point. Make your senior residents and attendings happy, and they'll love you. Get all the work done so everybody can go home on time. That's what will make them happy. But in the meantime, on your own, be studying and learning and paying attention to what's going on so you can learn. I'll do a separate video about how to crush radiology residency, where I'll go into a few other topics. But this was more of a generic thing if you're going into surgery or if you're going into internal medicine-based fields. Okay, hope you found that helpful.